Assalamu alaikum. I'm Afshan Khattak. I'm a pediatrician trained in newborn and pediatric intensive care. I hope to share insights into the current pandemic of SARS-CoV-2 or COVID-19 as we popularly call it, and I'm going to be talking about the disease progression uh, on molecular level as well as on physical level in a human patient. This talk is specifically for medics, medical doctors, nurses, other ancillary support personnel, and it is going to deal with some basic sciences related to COVID-19 as well. So basically, we are dealing with a storm of information about this disease. And we as medics need to be very careful and critical of information that we accept because our knowledge and practices have direct impact on many lives around us. Not only medically, but also because so many people look up to us for information about health and their lives. The objectives of this session are basically to appreciate the background knowledge because we need to build future diagnostic and therapeutic capacities in light of the existing knowledge that we have. And I really hope that the existing knowledge is coming from scientific literature and not, unfortunately, from social media as we are seeing these days. At the end of the session, I hope that the participants will be able to explain disease progression because this better equips us to anticipate complications and predict adverse outcomes. Hence, we are better able to prevent the adverse outcomes in the patients who experience them. Correlation is not well studied at all, and it is not because there is no work being done in this area, but the thing is, it is so early in the course of this pandemic that we need to at least begin to appreciate possible correlations with adverse outcomes in the progression of COVID-19. Then we also, I'm going to superficially touch upon possible areas of pharmacologic interventions, but this is not my area. So basically my talk is going to just give you an idea of possible avenues which are currently under study to find pharmacologic therapies for COVID-19 in humans. Coming to our first objective, the available background in literature, and I'm going to quickly go over the original papers, and they are all given at the end of this presentation in the reference section. So the earliest reports in literature came out in January of 2020 when a case series was reported by Huang et al. And we know the famous case series from Huanan seafood shops and seafood market and the disgusting videos of animals being sold and being consumed by humans that may have led to the pandemic of COVID-19. Following this came the well-known Lancet article and some others that documented larger case series and began to establish some risk factors for adverse outcomes with COVID-19. After the initial wave of articles from Wuhan, China, case series appeared from outside of Wuhan in other locations within China. Finally, Guan et al. Published the largest case series from China, confirming human-to-human transmission as well as establishing a spectrum of severity which was not previously described in literature. And then some predictors of poor clinical outcomes such as old age and systemic disease were also included in this series. Now, what is novel? I mean, this is a coronavirus, we all know that, and it is very similar to the virus that we know as SARS. So then what is novel about COVID-19? Interestingly, if you look at this schema, there is a spectrum of mild, moderate, and severe presentations that differentiate the SARS-CoV-2 that we know as COVID-19 from other viruses, other sister or brother viruses in the CoV family. This also adds to the potential of CoV-2 or COVID-19 to spread from mild symptomatic or asymptomatic contacts to cases to other contacts, and that is a long period, actually about around 5 days, as we will cover further in the presentation. So coming to objective 2, who are actually at risk? The patient profiles that are being reported and that were reported originally when the papers came out from Wuhan, China. We know that there is a clear patient profile now with certain demographic characteristics, and it is well reported in the literature, and we must keep it in mind when dealing with populations overall. A median age of 51 years with around 50-50 male to female ratio is now well established. Hospital admission, if it occurs, is within a week of onset of symptoms. Around 1/3 of admitted patients have comorbidities, so that is well established. And then cardiovascular and cerebrovascular diseases are the most common comorbidities that are reported in literature. Continuing further, fever and cough are most commonly associated. They're the most common symptoms, followed by fatigue and myalgia at initial presentation. Less common symptoms should always be asked about because they increase the index of suspicion, and we now know that dizziness, headache, shortness of breath, rhinorrhea, sore throat, and in a good number of cases, diarrhea are associated with COVID-2 or COVID illness. Some patients, the asymptomatic positive contacts came to light, and they are very important in disease transmission because they carry the virus in nasopharyngeal area and in their secretions, nasopharyngeal secretions, and are an important source of transmission of virus in their surroundings. I included this very nice pictographic image from Hindustan Times that they adapted from Lancet. And to me, it is an excellent example of science made easy for public. If you look closely at the picture, and I'm going to try to use my mouse here, if you can look at the presentation. The yellow box clearly shows the incubation period after virus enters the body at about 5.1 days, according to the Lancet study. Day 1 to 3 here marks the onset of symptoms, like cough, fever, which appears on day 1, while sore throat appears around day 3. The respiratory part of illness starts around day 4 to 9, which is marked by labored breathing. And this is actually a turn for the worse because the stage that resembles ARDS, the adult respiratory distress syndrome, may evolve between days 8 to 15 when the patient's immune response is fully active, and as you can see that 8 to 15 and beyond, only 5% of patients, while 80% of the patients will go into a complete remission after day 3. The lungs get involved in about 14% of cases, according to the study in Lancet from which the pictograph is taken. This means that a systemic shutdown-like illness resembling the sepsis cascade, by 3 weeks, which is the crucial period, and if you focus here for deaths here, people died between 15 to 22 days from onset of symptoms. So what is then the sepsis cascade, the crucial period, and what is the sepsis that is being right here. This is a systemic shutdown-like illness resembling the sepsis cascade from inflammatory mediators, or sometimes a superadded bacterial infection leading to an actual sepsis cascade. Deaths are common, as I said, between 15 to 22 days. Now, the asymptomatic stage that I described earlier, most index cases, that is the one case that is finally traced back to that resulted in infecting many cases in the population. So most index cases belong in this asymptomatic stage. There is a well-known letter to the editor in Lancet or New England Journal of Medicine, a case report which I have alluded to here, which described one case, an index patient that visited Germany here. Now this case entered Germany and he had a visit to Germany, flight to China, and then he started having symptoms in China here. And somewhere around day 7, see, January 19th to January 26th, somewhere around day 7, he had a positive PCR. But this index patient attended business meetings in Germany. He came in contact to the business meeting patient number 1, who came in contact with patient number 2, who ultimately came in contact patient 3, patient 4, and all these cases were traced back to this one index patient who visited Germany during the asymptomatic stage. All the patients ultimately turned out to have a positive PCR somewhere between 7 to 9 days after the exposure that they sustained with either the index case or the cases who came across the index case. So this is a very dangerous stage, and this is why most of community-based effort is focused on increasing awareness of general population to maintain social distancing, to maintain the cough etiquette, and for disposal of anything that the patient is coughing or sneezing into immediately. Now, stage 1, as I said, is actually a good stage, and we hope to have most of our positive cases escape the disease progression after 3 days. But an immune response, like I said, upper respiratory, fever, all those problems by day 1 to 3. However, unfortunately, if the immune response, which is the most actively studied phenomenon at this time, whether it is HLA subtypes, BCG vaccination, autoimmunity, many areas are being studied at this time to better understand the disease and to suggest possible targets for pharmacotherapy against COVID-19. Most of the tissues under study are the ones with high angiotensin converting enzyme 2, ACE2 receptor expression, because ACE2 is the primary receptor for the novel COVID-2 or COVID-19 virus that we know of. Also, recovered patients are currently under investigation to better delineate the cellular immune responses to COVID-19. That is why this is the current state of research. This is how the disease progression is being followed. So day 1 to 3 is the stage when most patients will not be symptomatic, but they will be transmitting the disease. Now, I'm going to go through a basic science schema, since we must possess a baseline understanding of cellular function to manage any disease. This is a schema with the reference I have given here that shows the progression of COVID-19 based on intracellular processes in the host cells. If you look closely here, we are looking at a lung. This is an alveolus. The pneumocytes type 1 and type 2 and blood vessel cells here. And this is the early stage, while this is the severe stage. So once the virus enters, it is presented, the alveolar macrophages will ingest the virus. where the virus will replicate and the messenger RNA will be transcribed. This is presented to activated T cells through receptors on surface of the alveolar macrophages. The activated T cells then give rise to the cytokines and chemokines. They release interleukins that actually lead to the cytokine storm that we know of, and which results in fibroblast proliferation here, and the hyaline membranes that we see in the alveoli, leading to the severe stage that resembles ARDS, or adult respiratory distress syndrome. So basically the purpose of giving this was to show you many targets for future immuno and chemotherapy of this illness, and to give you a basic concept of progression of disease as we see in patients who are admitted to ICU. Day 4 to 9 onwards. Now this is only 14% of the infected will experience this stage. There will be labored breathing and alveolar injury sets in at this time. Since I already explained the cytokine storm in previous slide, so this is when the patient, as we say in ICUs, starts going down the tube. Use of steroids around this time is under study and has been shown in studies from Spain to be helpful and to significantly reduce mortality in these patients. Chemokines and cytokines are present in high quantities in patients' blood, and drugs are being studied that are known to block the inflammatory mediators from acting on cells. Individuals with these diseases, as I said, especially after recovery, the cytokine storm will trigger a violent attack by the immune system on the body and may cause a multiple organ failure. Finally, that leads to death. This significantly resembles SARS and MERS, which are the other sister and brother viruses of novel COVID-19. Another flashback to molecular pathology, basically showing the progression of inflammatory cascade. I will not go into the details here, but I want all of us to appreciate potential target areas for further immunotherapy for this disease. This is the stage of entry. As you can see, the red bar here is the ACE2 receptor. Antigen presentation to the cytokine producing cells, the T cells in the blood. CD4 and CD8 cells then releasing the cytokines, which activate the plasma cells as well as the memory B cells. The only purpose, as I said, is to show you potential targets for future immuno and pharma therapy. Going further in the progress of disease, day 8 to 15, where only 5% of the infected patients actually will reach this stage, and the risk factors associated include patients who are advanced in years, older age, and with comorbidities that I already described during my literature review. So this is the severe life-threatening stage with heart and lung involvement. Cardiac complications also occur during this stage, and we now know that the novel COVID-2 directly causes myocarditis, but heart failure because of pneumonia is not uncommon in this stage. We also know that heart failure by itself is associated, has high association with ARDS, and actually can be a final pre-mortem event such as cardiac arrest, which occurs in 3% of inpatients with pneumonia. As I already described, old age, pre-existing cardiovascular disease, and other risk factors must be kept in mind at this stage. TROP-I is the serum marker used in these patients to predict adverse outcomes. Now we are going to go over some slides about temporal changes in certain serum markers in hospitalized patients. The reference is given here, and I highly urge you to go over the references and select the papers that you want to review, because these are some excellent papers and very timely, I have to say, that got published and that are disseminating excellent information to all the frontline teams who are involved with treating COVID-19. Now here, if you see, this is a graph. The blue line shows survivors, while the red line belongs to non-survivors. This is the level of D-dimer measured in serum of the patients, and this is the number of days. Around day 7, we see a dramatic increase in D-dimer in non-survivors. Similarly, the lymphocyte count. Lymphopenia is one of the cardinal markers of COVID-19, but as you see that non-survivors have more severe lymphopenia compared with survivors, and the split basically starts around day 7. More graphs showing serum levels of interleukin-7 and ferritin. And ferritin is one of the very important serum markers for disease progression. The one serum marker that I have not discussed here is procalcitonin. And I hope to discuss it in a separate session dealing with diagnosis and prognostication of COVID-19, because procalcitonin is key in prognosticating. But here I have included serum ferritin. This is interleukin-6 level in the blood, and as you see, around day 13, which is advanced, there is a dramatic rise in interleukin-6 in non-survivors. If we're looking at serum ferritin, around day 7, it plateaus, but around day 13, again, there is a dramatic rise, somewhat dramatic rise in serum ferritin level for non-survivors, while a decreasing serum ferritin level is actually a positive prognostic marker. Now the serum levels of TROP-I and LDH, and this is very important in patients experiencing the cardiac complications of COVID-19. High sensitivity TROP-I, and as I told you already, after the critical stage, although there is some rise in non-survivors, but dramatic rise around day 16 after week 2. Week 3, where most mortality occurs, we see a dramatic rise in TROP-I, as well as a later rise in the level of LDH in non-survivors. So these are some graphs, and as I said, procalcitonin I will discuss in detail in a separate session. But this is what is studied so far and given very well in an article in, I believe it's Lancet. Now, this final slide that I'm going to show you is actually about a graphic representation that gives a clear timeline. It cannot get any better than this actually, thanks to the authors and thanks to Lancet for publishing this. The graphs show factors in survivors versus non-survivors. And as you see, I would like you to focus on these graphs. This is the pictograph for survivors, while this is non-survivors. Fever, cough, dyspnea, ICU admission, which occurs in a sizable number in survivors. Systemic corticosteroid use, SARS-CoV RNA positive, which almost starts at day 1 and goes till the end. Sepsis and RDS has occurred in survivors. While looking at non-survivors, the only big difference that we see here in this red, it's absent here, is invasive ventilation. And acute cardiac injury, acute kidney injury, after day 15, as I said, that the patient goes down the tubes, there's secondary infection and death by day 19 in these patients. So basically, this is a nice reference to keep, to study the course of illness and to understand and to better be able to prevent complications and adverse outcomes in patients suffering from COVID-19. This is all. If you have any questions, you're most welcome. Here are my references, and once again I would stress that references in your free time and study them and refer to them as frequently, because there is a wealth of information out there, but not on social media in actual scientific literature. Thank you. Assalamu alaikum.